So our main goal is distinguishing focal disease from diffuse disease there. We're actually pretty good at distinguishing polyps from cancer, from fibroids, but we're not good enough. So bottom line, focal masses go in the bucket. Focal masses are surgical masses. Preparation is key. We already had the quote from John Wooden, if you like military metaphors for semi-surgical procedures, a pint of sweat will save a gallon of blood. So we schedule a patient early in our menses. We give some Motrin a couple hours ahead of time. You want to be a nice person and she'll be less anxious. There are a couple other exceptions here, but those are so unusual. Just take a look at the paper we wrote on this. So why scan during days 4 to 7? Well, there's a couple reasons. Number one, you don't want to scan a pregnant patient. You don't want to put a catheter or fluid in there, so that's probably the main reason. Number two, you're not going to have as many false positives, both in the adnexa and in the endometrium, because you're not going to have as many ovarian cysts that you have to follow, and you're not going to have the really funky appearance to the endometrium. So here's an example from a really nice paper by M.J. O'Neill, and she shows on day 23 this very lumpy, bumpy secretory endometrium. Could any of these be a polyp? Sure. Could any of these be a cancer? Sure. And then she brings her back, and on day 5, it's completely normal. So if we scan patients in the second half of their cycle, we're going to create a lot of havoc. So we just want to make a habit of scanning everybody early in the cycle, then we get beautiful images like this. Now obviously some women with abnormal bleeding aren't going to know when their period is, so you just take them when you do them. But many times you can make these studies diagnostic. Here are 2 different patients who had blood in their cavity, but you use the probe to kind of blot it, break up the blood, suck the fluid in and out, and you can generally get a diagnostic study. It just takes more work. So in terms of timing, what's the optimal time to schedule either transvaginal or SIS? You have a bunch of options, and again, the optimal time is day 4 to 10. Now you could say day 5 to 9, day 4 to 9, but somewhere in there. What are the risks? Patients usually experience a little cramping because you're distending the endometrial cavity, so they think they're having their period. They may or may not have a little bit of spotting. You want to consent them for infection, endometritis, or UTI, but knock on wood, I've never had one. These are really, really unusual. Vasovagal reactions do occur. I've had 2, and they've been very severe, so you want to be very gentle when you're inflating the fluid there. One of the things we worry about, one of the theories for endometriosis is retrograde menstruation. And you think we're putting fluid in and washing the endometrial lining into the peritoneal cavity. So that is a theoretical concern, but without going into the details, it's not a practical concern. It doesn't happen. In the same vein, you have upstaging. You're scanning postmenopausal patients who are bleeding, who may have endometrial cancer, and do we worry about blowing the cancer cells out into the peritoneal cavity and upstaging them there? We had a nice paper where we put baggies over the end of the fallopian tubes and then did SISs in the operating room, collected the fluid and looked at it. So bottom line, it's theoretical concern, but it's not real. And there's lots of data saying that prognosis does not change when you do an SIS or an HSG in patients with endometrial cancer. And finally, perforation should essentially never happen. Here's our typical tray setup for an SIS. You can, modify this however you want. The catheter, like so many things in life, it's the operator, not the equipment. This was a nice study where they used 6 different catheters in 600 women, and there's not a big difference there. We tend to use these specialized endometrial or SIS catheters that you see on the left, which are more or less modified Foley catheters. I like these, but if you're doing mission work in Africa, you can use a small diameter Foley. You can use a 5 French Soles catheter. In the middle is an example of a Goldstein catheter, so all these things work. Choose the correct speculum. There are basically 2 types of specula. There is the Peterson and there is the Graves right there. It doesn't matter that much, but a medium Peterson's kind of small. It's nice to start with. If you have a multip who's obese, you may want to go with a large Graves there. Try to get the lighted speculums if you're lucky enough to have them. Many places aren't, so we just use the standard metal. You want to insert the speculum. Oh, and backing up, in terms of the type of speculum right there, if you have it, get the kind that is open on the side so that it's easy to take the speculum out without dislodging the catheter. But again, many times we don't have access to those, so you just have to feed the catheter down the speculum while you're removing it, and that works. To insert the speculum, make sure it's warm, make sure it's lubricated. When you go in at a 45-degree angle and cheat posteriorly, because the anterior introitus near the urethra is a lot more sensitive, so come in and push posteriorly. Once you get it in, turn it straight up and down. And here's just a diagram from Bates's guide, just beautiful images in there. Then you open up the speculum, and here is the os, just looking at it straight on right there. This is where you want to spend your time. You really want to get this picture right here, have good lighting so that you can get this, because if you try to cut corners here and the os is off to the side, sometimes you can pass the catheter in, but sometimes it gets very difficult. So do it this way and it works easier. The next most difficult part of the exam is to pass the catheter right here. And people ask, well, how often are you going to have problems? And the answer is it depends. If you have an 80-year-old who's never had kids, you're more likely to have cervical stenosis. Whereas if it's a 40-year-old who's had 8 vaginal deliveries, it's probably going to go pretty easily there. If you have a cervix that you just can't get through, the first thing I generally try is a uterine sound. Always use the smallest one. Our trays come with all of these, but I always use the skinniest one. Remember, we're not sounding the uterus. We're just trying to get up the cervix. We just want a little bit of pressure right there. You can use a specialized catheter. A buddy of mine who's an REI doc told me about this egg retrieval catheter. This is really nice here. This is the patent egg retrieval catheter, but I'm sure there are other brands out there. You can just use a conventional 0.38-inch glide wire and put a 5-French dilator over it, and that'll work. You can also use a tenaculum, but remember that if you use this, you want to apply it properly. So the cervix has, let's get back to our diagram here, the cervix has its blood vessels coming in at the 9 o'clock position and the 3 o'clock position. So you want to put your tenaculum at noon right there. And again, we are not doing surgery, so you need just a little traction. So just put that down, one click, go very slowly, and you'll get enough purchase right there. When you put the balloon in, put it in slowly. When you inflate the balloon slowly. When you infuse saline slowly, and that will militate against a vasovagal reaction. Remember that you could have a polyp hiding behind the balloon in the lower uterine segment, so when you're done, you want to deflate the balloon and then just pull out so that you get a nice look at things. You want to try, as you get more experienced, put the catheter in the cervical canal. We had a paper in the Green Journal a couple years ago where somewhat counterintuitively it actually hurt less if you inflated the balloon in the cervix than in the endometrial cavity. So this is from the literature here, just showing the balloon inflated in the cervical cavity on a hysterosalpingogram. And here's one of our studies where we've got the balloon inflated in the cervix right there. And the nice thing about this, A, it hurts less, and B, you use less fluid because you don't have to do pull-out imaging because you can see the entirety of the endometrial cavity. The flip side to this is that about 10% of the time the balloon's going to pop out and you have to put the speculum back in. Again, failure rate depends totally on your pretest probabilities right there, but it's around 10%. As you get better, you'll have many fewer failures. And remember that gynecologists working in the office, 10% of the time they can't get in at office hysteroscopy. What are some of the false positives and problems? You can have air bubbles, the balloon obscuring the lower uterine segment, crud mimicking polyps, mechanical shearing of the endometrium, doing your study at the wrong time in the cycle. So here's an example of air bubbles right there, and you can generally figure that out real time. Again, we have to deflate the balloon to examine the lower uterine segment properly. If you have some grunge within the endometrial cavity like we do here, you can deflate the balloon, kind of scoop it in, break it up, suck it out, put in more fluid, and then you get a really pretty study. You can have blood clots that mimic focal masses, as we see here. Could any of these be a polyp? Could any of these be a cancer? Absolutely. but we spent some time breaking these things up, mechanically sucking the fluid out, and in the bottom right you can see we get a pretty study after some effort. If you're scanning in the secretory phase, which you really don't want to be, but you can shove the catheter in and raise a flap and get a false positive for a polyp.